Hi, for confidentiality, client names have been altered. I'm working with a couple, Seb, 35, and Eve, 28. They've been together for 13 years and have two children aged 6 and 7. Seb explained their reason for couples counselling is that he would like a third child, but feels Eve doesn't want to be intimate as she is depressed. Both have completed year 10. Seb is self-employed, though work is inconsistent. Eve has limited TAFE qualification and worked until their first child was born. And there have been times in the past where income was mostly via social security benefits. Seb has a history of drug and alcohol misuse, and Eve uses hearing aids. Seb was Eve's first serious relationship, moving away from family and friends to be with him, and described her childhood as loving but strict, and both her parents are now deceased. During her initial individual session, Eve disclosed that she doesn't want a third child as she is experiencing domestic violence, which started early in their relationship. Further, she feels despair, is crying every day, and is fearful of potential harm from Seb towards herself and their children if she were to leave. And this was her main reason for previously denying experiencing domestic violence to family, friends, and police. Eve described Seb as controlling, demeaning, and verbally abusive towards her, and there were acts of aggression, which involved damaging the house and possessions. He has called her a slut, and she further noticed that these seemed to coincide when she was going out with friends. Eve further described feeling humiliation and fear, which were impacted by also feeling insecure relating to her hearing impairment. To minimize the domestic violence, Eve stopped going out. When telling Seb she wants to leave, he responds with remorse and pleading for her to stay. Due to the disclosure of domestic violence, I utilised the Domestic Violence Safety Assessment tool developed by the New South Wales Government to assess their immediate safety and risk. The results were that Eve is at threat, with recommendations to make a referral and provide support. At this point, I did discuss making a warm referral over the phone to a specialist domestic violence counselling service, which she declined. And respecting her autonomy and dignity of risk, as outlined in the PACFA 2017 Code of Ethics, we then discussed safety planning, and I provided contacts that she could call if needed. The ethical considerations of client autonomy, client safety, and principles of non-malfeasance, as outlined in the ACA and PACFA Codes of Ethics, along with the potential risk factors of Seb's history of alcohol and drug misuse, the occurrence of domestic violence, and Eve's desire to leave, need to be considered as to the appropriateness of couples therapy in this case. Research by Carr, 2014, Herles and Coten, 2018, Carricott and colleagues, 2016, and Antunes, Alvarez and Di Stefano, 2014, reviewed the efficacy and considerations for couples therapy when interpersonal violence or substance abuse is present. These reviews of multiple studies found that there was no increase of harm to the victim, whilst also finding a reduction of domestic violence and substance abuse. They further strongly recommended that couples therapy go ahead when domestic violence is situational rather than coercive, when partners are able to agree that violence and drug use is occurring, that there is taking responsibility for aggressive behaviour, a demonstrated motivation to change, and a commitment from both to stay in the relationship, whilst also further stressing in regards to the counsellor that they engage in regular supervision with a counsellor experienced in interpersonal violence with couples. Absence of these factors could negatively impact Eve's physical and psychological safety, as couples therapy could be seen as validating Seb's abusive behaviours and cause escalation of abuse experienced in the home. Further, my ethical obligation to wider laws and exceptional circumstances as they relate to the New South Wales Children and Young Person Act 1998 places a mandatory reporting requirement if significant harm to children resulting from exposure to domestic violence is present, which may require a breaching of client confidentiality if I have reasonable suspicion of harm to their children. Thus, it is important to ensure that limits of confidentiality regarding significant harm to others, as well as what information may be shared and between the couple and referring agencies if required, are fully explained. As in the event of a mandatory report being made or a report of significant harm, this could be viewed as a breach of trust, resulting in one or both terminating therapy, which for Eve could further isolate her, with an impact being an escalation or worsening of her situation, and make her hesitant to reach out for help next time. My plan for working with this couple will involve another individual session with them both, with a determination for either referrals for individual treatment or engagement in couples therapy to follow. In a separate 2014 paper by Caracourt and colleagues, they stress that individual therapy is recommended where partners are fearful of each other, have different stories relating to violence and conflict, where there is presence of substance of misuse or abuse, and when one or more partners aren't committed to the relationship. In adhering to the ethical principles of autonomy, dignity of risk, and client sessions safety, in my session with Eve, I will explore with her the process of couples therapy, her commitment to staying within the relationship, and desired outcomes from couples therapy, as well as her feelings of fear of Seb and her ability, as she sees it, in discussing the violence within their relationship with him, as well as engaging in further safety planning regarding her and the children's safety, if there is a need for me to make a mandatory report. During my session with Seb, I would not raise that Eve disclosed interpersonal violence, whilst I feel that there are aspects of the domestic violence that may resemble situational violence and indicate that, such as maladaptive emotional coping strategies from Seb due to potential fears or anxieties. I am at this point uncertain that there are not also aspects of coercive control. Thus, to ensure Eve's safety, I would not disclose that she's let me know about the domestic violence. Thus, with Seb, I will explore his understanding of what arguments and conflicts within their relationship look like and what impact he feels his substance abuse may have on their relationship, as well as assessing his motivation for change and his expectations and the process of couples therapy. An additional consideration from McCann's case study in working with couples experiencing situational violence is that therapists must acknowledge that a potential consequence of therapy can be heightened emotions, as well as even when it's situational violence, that it could escalate and become coercive control, which may mean that individual therapy or further interventions are required at that time. It's important to be mindful of that. In the case of Seb acknowledging and taking responsibility for the violence in their relationship, agreeing to a separate referral for his substance misuse, and Eve's willingness to work on their relationship and her feeling comfortable and safe to discuss issues with Seb, and then both agreeing to the boundary of openly discussing safety requirements, as well as the potential of reporting an event if significant harm is a concern. And in my case, as a counsellor, I would require further session supervision with yourself, and I would also contract another supervisor who specialises specifically in domestic and family violence. If all these requirements were met, I would be comfortable at this point to move forward with couples therapy. In this instance, I would use behavioural couples therapy as an approach, as Kleinholz and Spencer, 2022, and Carr, 2014, have found this as an effective approach where interpersonal violence and substance misuse is present. To further address risks of client safety, I would utilise pre- and post-sessions with both clients to gauge their feelings and concerns around safety going home together, as recommended by Caracourt and colleagues in a 2014 paper. If either Eve feels unsafe or is not committed to staying in their relationship, Seb is unable to acknowledge and take responsibility for his abusive behaviours or willing to seek additional support for his misuse of drugs, I recommend that couples therapy is inappropriate at this time and make relevant referrals for individual therapies for them both. A further ethical consideration may eventuate if Eve is reluctant to speak to another professional. In this case, I would be willing to take her on as in individual therapy, with the understanding that if couples therapy is feasible in the future, I would need to assess with my supervisor if a referral to another family therapist would be required. Thank you for your time, and I appreciate and look forward to receiving your feedback, suggestions, perspectives on this case.